moving forward. So let's go back to questions.
So our last couple questions here. So a patient is following up for their new diagnosis of early stage dementia. She inquires about these disease-modifying therapies, and you discuss the risks and benefits. Which of the following adverse events is not often, or is most often associated with anti-amyloid therapy? Just learned about the vasogenic amyloid therapies show greatest benefit in patients diagnosed with AD at what stage of memory decline? That these new medications actually show greatest benefit throughout the course of this talk. So our key takeaways today, that cognitive impairment can often go undetected, sometimes as often as 40%, including hopefully increasing patients' ability to decision make with their families and increasing their quality of life, especially. So screening for those annual wellness visits, but just with a observational kind of question. Last thing we're going to do is re-look at those post-activity questions and see what you've learned during this session here. The 65-year-old healthy patient is presenting for their first annual. Following is required during the annual wellness visit for a patient. I hope that everyone will get this right this time around. Post-activity 2, this is a 78-year-old patient in the office for follow-up their hypertension. They've been forgetting to take their hypertensive medicines many days of the week. They also mentioned that they misplaced their car keys many times recently, and once they forgot their grandchildren's name on a phone call. You notice that they appear more easily distracted and that they struggle to make simple decisions as to where to sit during the session. All of these point to the diagnosis except cognitive impairment, except for which one? And our post-activity question number 3 is the 71-year-old patient who was recently diagnosed with early stage Alzheimer's dementia. How would you counsel him regarding this category of therapies? Thank you. And I think, Dr. Kushner, you're back.
Hey,
just to give us some questions.
It's like Amanda, Aracet, there's a question as to how long to keep them on, and is it still worth putting people on?
You want me to take this, or do you want to?
Sure, it does matter.
Sure. The data we have, I guess, top evidence is from clinical trials, and most of the trials were 6 months, some 12 months, very few were 2 years long, and so we actually don't have, so we don't know for sure if they will have ongoing benefit beyond that time frame. And so clinically, I often will continue treating patients, but I will potentially back off after a couple of years if we don't see a benefit anymore. And keep in mind, on average, the benefit is a modest improvement, so it's not necessarily slowing of cognitive decline. And so if you're seeing that there's ongoing decline, it's not clear that it's helping anymore, and so it's okay to consider coming off of those drugs. More importantly, if you have side effects, or if you have difficulties taking medications, or there are issues with polypharmacy, again, if there isn't really evidence to support this, then it's reasonable to come off of that.
So when patients ask about these emerging therapies, what would you say, how can we stop that step if there are serious adverse events that these patients would not qualify for the emerging therapies? What do you
hear all the question you have?
Well, saying if there are adverse events that would make them ineligible to receive
Correct.
that treatment. I mean, so that is a real concern. I mean, so there, if you're at greater risk of developing, say, these amyloid-related imaging abnormalities, until we have a real-world experience with them and how common they are as opposed to what we've seen with clinical trials, I mean, we
do it.
So it would potentially, ApoE with the ApoE4 version is a susceptibility gene that increases risk of developing Alzheimer's disease. It doesn't determine that you will, but increases the risk. But what we've seen, and probably because it also has a relationship to amyloid and vascular changes in the brain, is that if you have 1 or 2 copies of the ApoE4 gene, you have a higher risk of the ARIA-E, or vasogenic edema manifestation, and it actually with 2 copies it's a substantially higher risk, and so that is something to consider in terms of whether or not you want to risk that and go on a treatment like that.
Okay, and I know you discussed this, but this has come up, so this is for you, Amy. The MOCA and MMSE can't be used because of copyright protection. Is there another diagnostic test that you use for dementia?
Well, you know, I do understand that they can't be used for copyright protected issues. I still will often use the MOCA, the MOC.
Big difference because it could be a depressant condition, and so it's quite messy.
Especially now with whether or not they might be appropriate for trials, I would probably recommend for earlier rather than later. If someone